Thank you for having us back to present A to Z, a year in review. So this is from spring 2015 to winter 2016. So neither Patty or I have any real or apparent conflicts of interest to report. So the learning objectives for this presentation are to review the purpose, objectives, and search strategies and associated limitations of the literature, reviewing this literature, reviewing the topics, the methods, and the findings, and then the journals from which they came from, highlighting the gaps in nursing informatics research, and discussing opportunities for translating the informatics evidence into clinical practice. So we surveyed the literature in the area of nursing informatics using this criteria. We were looking for research studies. This included systematic reviews, randomized control trials, observational and qualitative research, and case studies that were focused on nursing informatics and were published between March 1st, 2015 to February 29th, 2016. And so we'll describe for the set of literature that we found, the author countries, the settings, and the topics. And then we'll do a deep dive into a handful of these studies. So our search strategies, we looked in PubMed and CINAHL. We used the terms nursing informatics and combined that with research and interprofessional, and then those dates that I mentioned. So our inclusion criteria were research, that it contributes to nursing informatics knowledge base, including prototype development and testing, clinical care delivery focus in informatics. And that we did exclude articles that were focused just on informatics education programs, nursing education, nursing students, competencies, and simulation. Not that we don't value that work by any means, but we were trying to focus on what articles we can read right now and translate to practice, in the near term. So we retrieved 590 articles, and then 17 were identified from all of you through NENIC members. So from that, when we did an abstract review and looking at duplicates, we excluded 483. And so we were left with 124, and then applying our criteria, looking at those full texts, 43 were excluded, and we were left with 81, which I believe is about double what it was last year. So that's awesome. The journals that they were coming from. So the 62 there is other. So this is a mix of different clinical journals for the most part, that these studies were in. So, a lot focused in specialty clinical areas, which is really, really great to see. And after that, a lot in CIN. We have a handful in IJMI, so International Journal of Medical Informatics, a good amount in Journal of Clinical Nursing, and then some in JAMIA as well. So the countries, the US had most of the pie here, but also I think, actually, it looks like, I didn't realize that. I think other is might be the 11 there, but a good amount from the UK and Taiwan. So these were the settings and the topics. So the settings were ambulatory, community, public health, continuum of care, just focus on health professionals and expert panels, hospitals, long-term care, and then other. And the topics that we'll do a deep dive into: handoff, transitions of care, consumer health, implementation, clinical decision support, human factors and usability, standards, terminology, interoperability, and health information exchange, mobile health, e-health surveillance, big data, information seeking, clinical documentation, and other. So of those, most of the studies were focused in the hospital or acute care setting. A good amount were focused across the continuum of care, and then fewer, but still a pretty good amount were in community, public health, and ambulatory. And I'll point to that long-term care, it seems like it only has one there, but we'll actually talk about a few studies. So they really ended up being grouped in the continuum of care because it was looking at care transitions for a lot of those. So research topics, consumer health was number one. We certainly found a lot there, and also mobile health. And there can be some overlap there too, talking about mobile applications for consumers. And then clinical decision support, a good amount, and standards, terminology, and interoperability, which is exciting to see in the context of our discussions this morning. And 6 in big data. So great to see. I think that's more than we've had before, and hopefully even more next year. So these were the NENIC publications. So we had received 5 of them from NENIC members last year, and so certainly way up there at 17. So great job. Okay, so now we'll go into some of the topics. So transitions. So this is a study focused in long-term care and acute care. So what they did here is they had kind of this multi-component intervention. They were looking at long-term facilities and then patients being transferred to acute care and within this health information exchange in Oklahoma. And so they implemented some secure messaging using HL7 standards. They were using Cerner. And then they had a few different structured documents that they were using. So they had a CDS component that actually alerted the nurse if the patient wasn't doing well, that they could intervene before the patient had to be transferred to acute care. And then, but if the patient was not doing well, so they had to be transferred, they used an SBAR structured document, all electronic tools. And then during the transfer, they had another structured document for that. And these were all electronic tools that were then right in the room, as they described a usable way. So they found that the tools were used in 83% of the transfers, and they found that readmissions decreased and return emergency department visits were also lower after the intervention than baseline. So another study focused on transitions was looking at electronic messaging of patients that were admitted to the hospital and messaging back to their home care, like the home care kind of community providers that knew of these patients and were tracking them. So what was interesting is it was during the hospital stay, but they were sending these messages to the outpatient setting that would be coordinating their care after they left. And so this was a qualitative study where they did interviews, essentially asking them what they thought about the messaging, and if it was beneficial, if it was efficient, talking about the quality and safety that these nurses perceived in using it. So they found that the messaging was more efficient, less time consuming, that then when they were writing these, typing or writing these messages, they were more thoughtful in the content that they put in it than when they were just having a verbal exchange. But they were a little bit concerned about the information security of it, mainly about what do we do if the system goes down, and then we can't quite retrieve the message anymore or use that messaging. So, I think kind of capturing some of the pros and cons that people feel maybe at implementation when they're getting used to those systems. So standards, terminology, and interoperability. So this is an excellent paper that I encourage all of you to read. It is. I didn't tell Patty I was putting it in here. Especially in light of what we've heard this morning too. So a lot of us here have systems where the content is in there. We've developed the systems, implemented them. So how do we actually standardize that content? So what they did here is they were looking at the documentation that existed across, I think it was 6 large organizations, and how from the ground up can they create these data models and then map them to standard terminology. So, they did that work, they consolidated what those models should be, and then they were mapping them to the standards. And they found that, the content that the clinicians needed was not represented in all of the standards in SNOMED and LOINC, but they describe very well the process to get those standards in there. And that they worked with the standards organization to request things, and sometimes the organization said, no, we wouldn't put that in, but then had the discussion about why it mattered and where it would fit then within the terminology. And so really, really practical, very, very useful to kind of see that methodology that can be used and how how you really can work with these standards organizations and get the content in that you need. So this one is focused on health information exchange capabilities in skilled nursing facilities. And so they did a survey here of nursing home administrators to analyze essentially what, health information exchange sharing they had at their facilities. It was a decent response rate, 39% response rate, and they found, maybe not surprising, but that the intra-facility exchange, was pretty high across all of these, and less exchange was happening when it was with non-affiliated organizations. And they found that it was more prevalent for-profit and skilled nursing facilities. So mobile health. So this was titled A Modified User-Oriented Heuristic Evaluation of a Mobile Health System for Diabetes Self-Management Support. So what they did here, this was a patient-facing, consumer-facing system to track diabetes care. And they were doing the usability evaluation of it, but they were trying to find out, so Nielsen is well known for a heuristic usability evaluation and the components that you should look at. They were trying to see, is there a fast way or a more efficient way that this can be done for tools like this? Who should be doing it and exactly how? So they just modified some of Nielsen's criteria, and the main thing that they were pointing out was that using dual domain experts is really beneficial. And I just wanted to make the point that, I think everyone in this room is a dual domain expert. So expert in nursing and in informatics. And by combining that, they found more usability issues that weren't detected by just those single domain experts. So one example is, noticing that, and I think this is showing that the dashboard needed more time, needed to show glucose more than once a day. Because patients that are diabetic are going to be tracking it more than once a day. So if you're just looking from kind of that informatics IT focus without having that clinical domain knowledge, you're going to miss that. So mHealth text messaging intervention to promote medication adherence. This was an integrative review. So, it's at the point in the literature, there are a fair amount of studies looking at text messaging to patients to increase their medication adherence. So they found that the literature points to the fact that there are benefits. It works. We're at the point when, there's a lot of variation in how these interventions are deployed, essentially, or implemented. So the doses range, but this can be because they're different types of patients, too. So sometimes 3 messages a day, sometimes 1 every few months. But they measured adherence differently. Some were self-report, some were refilling your prescription, some were, that metric where you can measure when the prescription bottle is opened or not through some electronic mechanism. But they found adherence overall increased. And right now it's just a matter of maybe refining the actual guidelines and implementation of what these messages should say, and specifically, how frequently they would be sent and so forth. So this is assessing the impact of telemedicine on nursing care in intensive care units. Really interesting. I don't know if any of you work in tele ICUs, but they conducted this with, I don't think the number of nursing units is on there, but they had 1,200 respondents, so a lot throughout the country, and just on their perspective of it. And so they, were in agreement overall that they were accomplishing tasks more quickly, improving collaboration, improving job performance, improving communication, that it was useful for nursing assessments, and providing more time for patient care. So they identified some important priority areas for tele-intensive care unit nursing. Number 1 being critical thinking skills, being expert clinicians with experience, having good communication skills, and so forth. That, I think this certainly is an emerging area, and for people to build the competencies in. So this is Patty's paper, which won the Harriet Worley Award this year at AMIA. Excellent, excellent paper. And I chose to highlight it because it's really, really, really practical for anyone implementing iPads and tools at the bedside in a hospital setting, and the device management that you need to think throughout it. Things like, where are we going to put it? How do patients, hold it? Where do they plug it in after? Dealing with the information security, how's that handled? How do you do that? What do you tell the hospital administration about those processes and how to hook into the existing ones? And then infection control. And actually, I think it was a couple years ago that we highlighted this Albrecht paper on the actual way that you can wipe down an iPad in the hospital setting to decrease any sort of infection rates. So nice to see it coming together there. Oops. Human factors. So this is exploring nurses' reactions to a novel technology to support acute healthcare delivery. The main point of this paper really is that we need to involve nurses early on and engage them in the design of tools. It was a really kind of interesting approach that they took. They had this, from what I could gather, I read it a couple times, but I think they were they made up a tool. It wasn't really real. But they were saying, what do you think about this? We're going to deploy it and implement it. And the nurses just kind of reacted to it, and they're like, oh, I don't know, that might threaten, kind of our workflow, and, those typical reactions you might get. So they looked at, what were the challenging reactions, what were the enabling reactions, but I put up these two graphs because these are two different units or two different sites, and they essentially showed that their reactions were totally different, between the two sites. In terms of what they thought might be good and might be bad. So I guess it speaks to the fact that you don't really know what the reaction will be when you enter a particular unit with a new innovation, and so engaging them early on in that design, and how it would fit is kind of what this is, emphasizing. So this is evaluation of SysOM, a computer-based animated tool to elicit symptoms and psychosocial concerns from children with cancer. So this is work done from Cornelia Ruland's team in Norway, and so she's a co-author on here, and it's an extension of work that she's done with adults, essentially an application, so that they can choose electronic application. It's this really cool visual with islands that they can choose the symptoms that they're experiencing. So the point is to kind of give them, I think, a better way to document their symptoms. And they were comparing this to the existing tool and how children with cancer document their symptoms, and they found that they were able to gather more symptoms. Some of the parents then reported, wow, I had no idea that my kid was experiencing that anxiety. They didn't tell me that they were. So seems absolutely very, very useful. Handoff. So nursing handovers as resilient points of care, linking handover strategies to treatment errors in the patient care in the following shift. So they did observations here and then chart reviews as well. And they were essentially, during their observations, coding the strategies that nurses used in handoff. That's what you see labeled there in that table. So were they having face-to-face communication? Did they limit interruptions? Did they check the medical equipment? And what they found was that when they did, pretty much, I think, if you see the asterisk, that means it was statistically significant. So pretty much all of these things during handoff, they had fewer errors in the shift following. And the errors were dosing errors for medication. It was mostly all focused on medication. But interesting study that they weren't structuring the handoff in the get-go. They were just observing what they were doing and associating it with errors or a decrease in errors. So then there was an integrated review of handoff as well. Now both were this year, so the study I just presented wasn't in this review. Just time-wise, it couldn't be. And what they found here was similar to what I think we've known for a little while. There are a lot of mnemonics for handoff. They are being used. We still need to study them better to really differentiate which one's the best and what is it about it that is, benefiting patient care. Some of the interesting things that this review brought up were that the nurses were worried about things such as confidentiality when they were then, they were giving handoff at the bedside or, more in a public area. And those were some of the concerns that seem to be pretty consistent across these studies. And on to Patty.
Thank you, Sarah. Hi, everyone. Glad to be here again. And consumer health. So this first paper, actually, Sarah is a co-author on this one. The purpose was to investigate internationally the current state of approaches for providing patients with access to their own clinical information. So this is the same team. We reviewed a paper last year where they looked at portals, and so here they were just looking at, what's the status of information sharing in different countries around the world, and they did a pretty nice sampling. Now, it was a purposive sample. They sampled colleagues from around the world, but they were looking at a couple different factors. So, for example, they were looking at in each country, what's the maturity of the concept of patient engagement? Is this something that's really well integrated into the culture, or is it something that's just emerging? And you can see there's a whole range, depending on the countries where you are. I think US and UK and Australia had very established patient engagement, as a concept, but in other places, not so much. They looked at government involvement. So are there incentives that, policy incentives that might promote patient engagement? So in the US, we have meaningful use, right? So there's pretty good engagement here. They also looked at patient portal strategies because they found that patient portals was the most common way that information was shared with patients. And there were a couple interesting things about patient portals and there was a big discussion about who owns the data, and that really there wasn't like agreement about, organizations might think that they own it because they maintain it, patients think they own it because it's their data, but it's really only in the Netherlands where patients are allowed to go into their portal and actually erase stuff that they don't want in their record. It doesn't matter whether they put it there or not. And in Australia, they're allowed to hide documents from certain providers, but they can't take them away totally. So, but US is the only country that has open notes. BI, thank you. They also looked at national patient identifier as, another way of sort of facilitating this sharing. I think one of the other interesting things is they found that on the countries where there was more data sharing, these were countries that had done a lot of implementation. So they're no longer focusing on implementation, but on I was thinking about it as like Maslow's hierarchy, right? So in countries where they were doing a lot of implementation, or that's where their focus was, they didn't have this concept of patient engagement yet. This is a paper on investigating whether the quality of EMR improves when a patient's use a tool that's called EMR PCT to communicate asynchronously with the pharmacist about errors. So this was in the Netherlands. So remember, Netherlands, patients are allowed to erase their data. So this is the environment. And so they actually have a policy in the Netherlands around what the patient responsibility is, what the pharmacist responsibility is, and what the provider responsibility is around maintaining accurate EMR. And so what the pharmacists were trying to do here was engage the patients more in keeping the record accurate, because it's the pharmacist's job to really make sure that there's no errors. And so they used this tool. They invited about 300 patients to participate. They were all patients who had polypharmacy, greater or equal to 5 medications. About half of them accepted, a little less than half, and then about a half of them actually followed through and participated in the study. What they found, though, is that very few of them, I think 17.9%, communicated asynchronously with the pharmacist. So very few of them actually communicated, but many of them logged in and they looked at their record. And when they looked at, did it actually make a difference, in terms of the accuracy of the EMAR, there was no difference between the patients who logged in and used it versus the ones that didn't. It could be a sample size issue, though, because so many people didn't participate. They did find, though, that for patients who participated, their self-efficacy related to maintaining their medication and also their collaboration with the pharmacist, those scores were much higher in the patients that participated. So this is an example of, like, over time they might have seen a difference, but they didn't in this study. This is a study, breastfeeding and the use of social media among first-time African-American mothers. So I thought this was interesting because, we know how often social media is used. This was a qualitative study, an ethnographic study, where they did interviews with African-American women and their partners and looked at how often they use social media and online tools to access information about breastfeeding. And what they found was that while they use these online tools and social media for everything else related to finding out about their pregnancy and how the baby was doing and what the size was supposed to be and what they were supposed to be doing after birth, none of them could recall any information about breastfeeding. And so the message was, we're really not doing messaging well with this group. And if we want to improve, breastfeeding across all different segments of the population, we have to make sure that we're using the right messaging. And so I think it's good for us when we're doing these kinds of studies to think about that. Who are we targeting and what's our messaging? So this one was compare online with face-to-face help intervention in women experiencing intimate partner violence. So again, this is a vulnerable group of women, and they were looking at whether providing modules about how to get help with interpartner violence was better in person or online. And then they had this waitlist control. And what they found is that the women who got the online version actually had very significant improvement, and the ones with the in-person, not really. And so they thought, well, it could be that, women are embarrassed or uncomfortable. And so this is an example of where, informatics or online interventions can be better than face-to-face, and it's certainly more cost-effective. And this is they used the World Health Organization ecological model where they had outcome measures related to mental health on the personal level. So they looked at anxiety and depression. On the interpersonal level, they looked at anger and personal support. And then on the community level, they looked at the women's perceptions of social support and whether or not they were employed. So again, for the women who got the online intervention, they saw improvement across these domains. So this was personal health record use among nurses in the nursing informatics community. So a couple years ago, there were some informatics nurses who disseminated a survey using the Amy and HIMSS listserv to find out how many nursing informatics nurses were using PHRs. How many of you participated in that survey? I know I did. Okay. So the response rate, so one of the issues with survey research on the internet is you don't have a denominator, right? You don't really know how many people that went out to. But they had 183 respondents. And what they found is that the nurses who said that they did use an electronic personal health record tended to be over age 50, like most nurses, highly educated. Many of them held management positions. And they were more likely to have healthcare providers who used electronic records, and they were less concerned about privacy of health information. And what they said is that, nurse informaticists, our informatics nurses, are in a really good position to do modeling, really, to model, using a PHR to encourage other providers, but also to encourage patients. They're also in a good position to influence patient portals and make sure that they're usable and that the security issues are addressed so that people will use them. So the next topic is implementation. And for this paper, they were looking at determining whether implementation of barcode medication administration process could improve the safety of medication administration. And they did a pre-post comparative design, and they hypothesized, based on the literature, that after they implemented EMAR, they would have a closed-loop barcoding, that they would have more real-time bedside documentation, they would have less errors. But what they found was that while wrong medication errors decreased, other types of medication errors increased. And when they went back and looked at why this was, they found that the database with the medication dispensing system was not synced with their, with order entry. So in order to get the right medication, they needed to bring their cart on wheels next to the dispensing cabinet and match both that way, but there were workflow issues with doing that, so many of them just sort of used jotted down notes and so forth. And so I think it makes sense that maybe they wrote down the medication and maybe not those other things, so you could see why there might be some issues with the medication. So I think it's just a good example how, we implement these technologies where, especially with closed loop barcoding, we know that this is a really fabulous patient safety intervention, but if we have problems with databases that aren't syncing, it creates problems, and we're not going to have optimal results. So for clinical documentation, this is a paper that looked at, he examined if nurses' perception of the impact of health information technology on their practice had a mediating relationship between electronic nursing care, reminder use, and missed care. So this is the conceptual framework. It's really done obedient, so you have your structure, process, outcome. Let's see, does this work? Yeah. So structure would be these nursing care reminders, the alerts you're getting in your EHR, and then the process would be the frequency of how frequently you actually use the reminders or respond to them. And then the intermediate outcome that he was looking at was missed nursing care. And so what this Ronald Piscotty, what he makes the point that basic nursing care, like walking your patient, getting them up, bathing them, all these things have all this basic care, when it's not done, can really lead to adverse events, right? It can lead to pneumonia or DVT or PE. So it's really important that, and there is evidence that having these reminders actually is associated with less missed care. So he looked at whether, when nurses perceive the impact of health information technology on their practice as positive, whether they were more likely to listen to these reminders and therefore not miss care. Does that make sense? And what he found was that, yes, the nurses' perception of their technology, the impact of the technology, did have a mediating effect on whether or not they responded to the reminders. And so he recommends that, that nurse informaticians and nursing informatics nurses are involved in looking at what are the perceptions of the technology, and when the perceptions are negative, that we look at both the systems and the workflow to make sure that we can correct any deficiencies. Now for clinical decision support, we have Sharon's paper. Where's Sharon? There she is. Okay, this is Sharon's capstone project from, she finished her DNP this year, and the purpose was to improve the knowledge of peripheral nerve injury in the operating room. And what she did was she designed a assessment screen with some decision support for nurses, and she also did some educational interventions. So this is a screenshot of the assessment that you can see it's integrated into the documentation screen in the OR. And she worked with the practice committee in the OR at the Brigham. I think one of the things I love about this study is that it's a good example of how in order to get a really good nursing decision support, you can't just create a rule, right? You have to think about, all right, so who are the people who are you targeting, right? You have to work with that group. You have to figure out where in the workflow are you going to put it. And then this was actually the assessment. And then for measurement, she also did some education with the nurses in the OR. She also did some chart review to see if they were actually using it. And then she looked at whether they were documenting their interventions to prevent peripheral nerve injury. And so what she found was, after this intervention, that there was improved documentation about peripheral nerve injury. She found that the educational level was better. Nurses were more responsive to seeing clinical decision support in their documentation. And this was particularly a nice paper to see, because last year, one of the things we said was a gap was were papers on nursing clinical decision support. So this is a good example. And so here's another paper from, where's Kimberly Whalen? There she is back there. So this is another excellent paper on nursing clinical decision support that was done by a group of nurses here at Partners. They wanted to understand the requests for nursing clinical decision support. This was before the Epic implementation across Partners. And so what they did was they looked at all of the nursing clinical decision support requests in the healthcare system, and then they categorized them using the data information knowledge wisdom framework. And so so for data, they looked at, is it decision support to facilitate data capture? Or for information, will it meet the information needs of nurses or patients? Knowledge, will it guide knowledge-based decision making? And then for wisdom, will it expose analytics for wisdom-based clinical implementation? That was actually categorized as something that couldn't be done for the initial implementation, but was a future state. Let's see. And so this table shows you that the majority of the clinical decision support related to alerts, and an example would be lab values that affect medication administration. So this was a really nice descriptive study that shows the types of clinical decision support related to nursing practice. The other thing that's great about it is it shows a strategy for, when you have to implement a new system, there is a lot that needs to get done, right? So you have to prioritize. And so it was really a strategy for looking at what's the short-term plan around nursing clinical decision support, and what's our future vision? And they sort of, took care of both of those at once. It's a really great paper. The next is big data. So this was, the purpose of this paper was to examine the association of nurse continuity with the prevention of hospital-acquired pressure ulcers. And it's a secondary analysis of a large data set from the HAND study. How many of you know the HAND study? So that was Gail Keenan had done this study in 4 hospitals from 2005 to 2008. She had integrated NIC, NOC, and NANDA. It was a care planning system. So they looked at retrospectively 840 care episodes, and then they used logistic regression to look at whether having a nurse continuous, or whether nurse continuity was associated with less pressure ulcers. And so this was their model. So again, it's really Donovan like your structure. So nurse continuity would be part of the structure. The process is, the assessment, the monitoring, the decision making, and any interventions you do. And then the patient outcomes in this case would be whether or not they developed a pressure ulcer. I think one of the most significant contributions of this paper is they were able to define what continuity is. And you can see it's pretty complicated because there were many different combinations of, for if nurses are working 12-hour shifts, there can't necessarily be, there's going to be, breaks in continuity. So, we have, wherever they have arrows, this is just showing in a one-day period, the continuity between nurses and patients. So there's lots of breaks here. And so what they found was that there really was they didn't see any association between nurse continuity and whether or not patients got a pressure ulcer, but it wasn't clear whether it was a power problem because there were so many different combinations of the continuity that I think it would be very difficult to measure. They probably needed more data to do that. What they did see was that pressure ulcers were associated when patients had issues identified with nutrition, mobility, perfusion, the things that we assess for on the Braden scale, right, when patients are first coming in. So, that was, I think it points to the complexity of nursing documentation, and they did a lot of thinking around how to define a very difficult concept, but we need more data, so we need big data. So, Bonnie's going to help us with that. Okay, so our last paper was written by Andy Phillips and Jackie Merrill. Is Andy here? I don't think I've... Okay, so this was to examine, their purpose was to examine the healthcare literature between 2004 and 2012 to look for evidence of technology transformation. And so the idea here was that during that time period, we had a lot of policy that was really meant to transform healthcare with technology. So they were looking for evidence of that in the literature. They used this punctuated equilibrium framework, and they did a very broad lit review. And what they found was, so this is what they expected. So on the top, they said, okay, so we have this very deep structure, which is our healthcare system, and it's sort of been moving along at the same, sort of stable for many, many years. And then we have this huge dose of meaningful use and all types of policy that's going to cause this huge transformation. So we're going to see discontinuity in the regression line, and then we're going to, after this transformation, we're going to stabilize again, but we're going to be way up here in terms of transformation. But what they actually saw was that the line was much more flat. And the reason, they said, was that there's so many barriers to change in our healthcare system, that there's so many environmental barriers, there's issues with ethics, there's competition issues with that people resist data sharing. And that one of the worst barriers that they identified in the paper was that we don't involve patients enough in the process. And so even though we had a ton of policy and money that was put into the system to really cause this transformation, it really didn't have the impact that we had maybe expected. It might, at least not yet. And so they recommend that we need, in order to have that kind of transformation, we really need to make some big changes with, really involving patients more, really increasing the amount of data sharing, and having more open policies around, data sharing and more open access and so forth. So that was just a very small selection from a lot of papers. Sarah and I reviewed a lot of papers this year. I think that you would agree that we had, I think one of the big changes we've seen over the last couple of years is a shift from papers being mainly in informatics and nursing informatics journal to the general literature. So the majority of the papers were not in informatics journals. These are just in nursing and healthcare journals. And so I think we're, not just talking to ourselves anymore, we're talking to everyone. The three most common research topics were consumer health, mobile health, and then, standards and terminology. We saw fewer studies this year published on transitions and handoffs. That was quite big last year. And we saw fewer on usability. That's another one that was one of our top categories last year. We saw more diversity in research settings. Last year, most of the papers were in the acute care hospital. That was still the largest category, but we did see a lot of other, we did see research being done in other settings this year. And then we saw a lot more contributions by NENIC members, which was great to see. Last year, we had identified clinical decision support for nurses as a very large gap, and there were 4 papers related to nursing clinical decision support that were written by NENIC members that were published this year. So that was so NENIC is filling the gap there. We are still seeing very few papers that are rigorous evaluations of the impact of health information technology on nursing care and patient outcomes. And so that's our charge for you this year, to do some rigorous studies. I know it's difficult, I think. I know that a lot of the studies that we do in healthcare, it's difficult to use like randomized controlled trials, for example, because they're very disruptive. So we have to think about what kinds of other methods could we use, like that would help us to get some rigor, but would allow us to study in these real world settings. And then there are very few papers related to big data. So again, Bonnie, we're looking for some papers from.
Nursing Research 2016.
That's right. Yeah. So all of you can go to the University of Minnesota Big Data Conference and find collaborators for big data papers, because we need more big data papers. So I think the paper that we reviewed related to the HANS study was a good one. But even with the number of data points they had, when you look at the complexity of nursing data and how much you lose when you clean it, right, or when you have a definition, I think as we start to combine our data sets, we'll be able to do some of this, but it's more to come. Okay, so who published something but didn't send it to us, or we didn't find it? Raise your hand. Okay, so this is a first, right? Usually we have, maybe we weren't as thorough last year or something. Okay, so any discussions about, did any of these studies strike you as particularly noteworthy, or is there anything we talked about that you're going to be able to apply in your practice when you go back? Cindy.
So Patty, I happen to have a hard copy of your article right in my bag, because I was going to read it today. Just talk about applicable. I think getting devices out there, particularly looking at, as you probably know, we're looking to get something at the inpatient side in the hands of the patient, which would probably be a tablet of some kind. So how are we going to manage that? So Sarah made sure I got that paper.
Okay, that's good. Yeah, I mean, something like that seems like it's sort of straightforward, right? Hand the patient a tablet. And so with the study that we did where we used tablets at the Brigham, the Prospect study, we had started out, we wanted to use touch screen devices that were going to be installed at the bedside. We found this great vendor. We had everything all set up, and then we learned that, wait, you can't do that. We're installing devices at the bedside for the clinicians, and we can't have 2 devices next to each other. So we had to come up with another plan. So this was like a couple months before we're supposed to go live, and all of a sudden we need a new device plan. It was, yeah. And so, at first we thought, okay, well, what's the big deal? We'll use, but there's so many things you have to think about. So for example, do you want to just give a person an iPad and let them, use whatever you're directing them to? So we had a portal and then everything else on the internet. So if you do that, that means that you need to wipe the data clean between patients, right? So you have to have a way of making sure that no one else is going to get to that before that's done. There's also the infection control. So I think it was last year, maybe it was the year before even, where we talked about that study of device cleaning. And thank God we reviewed the literature and we knew about that, because I used that paper to create the policy, because then we had to meet with the infection control nurses at the Brigham and also at Dana-Farber, because we were doing this with oncology patients. What they said was they approved our policy that was based on that paper, but they also said we could not bring devices in and out of the room. They had to stay in the room. Okay, so they have to stay in the room. We have to wipe them clean before, somebody else gets to them, both data and infection control. So, there's so many things you have to think through, as well as the partner security. Do you have everything, built so that it meets all the partner standards for data security? So there were many, many things we had to think about. We had devices in the intensive care units and oncology units at the Brigham for 11 months. And 2 disappeared. So I think we did like a pretty good job managing them, or at least our research assistants did. I don't think I could take the credit for that. But we did think about, there were lots of things to think about in terms of, what kind of messaging do you want to have on the devices so that, people at least would feel guilty if they started taking it out of the room. So all of that's in the paper, okay? Okay, thanks, Nick. All right. So this is where we really ran into the most. I think we paid $200 a month for new chargers, right? I think we became the source for chargers. You need a charger? Go to the prospect units and just take one of those. Yeah. So people did not take our devices, but they did borrow the chargers and never gave them back. Other questions? Okay, so we're just about out of time anyway, so I'm charging all of you to go and write about big data for next year. Oh, actually, I have an announcement. At lunchtime, Sarah and I were recruiting because we're retiring this year from, we love to do this, but we thought we should give other people an opportunity. So next year, it's going to be, where's Kathleen? Raise your hand. Okay, Kathleen. And Andy, is Andy here? Andy's not here. Okay, he didn't come. Okay. All right, so Kathleen and Andy are going to be doing this next year. Is that documented somewhere? Is this being taped? But they're both great choices because they have a lot of students, and I'm sure that will be a blessing for you next year when you go through this. All right, thank you all very much.